All right, chapter 6. Let's see if we can't make that a... Let's do this. Okay, so chapter 6, we are talking about mood disorders and suicide. So mood disorders, gross deviation in mood, different types or episodes. We're going to talk about major depression and as well as persistent depression and manic hypomanic depression, hypomanic disorder. So what does a major depressive disorder look like? What does persistent depressive disorder look like? Both of these things are common to DSM-4, and now we're going to elaborate on some new things in DSM-5, which are premenstrual dysphoria, as well as disruptive mood dysregulation disorder. The bipolar disorders still stand. They're bipolar 1, 2, and cyclothymia. So major depressive disorder, what does that look like? Extremely depressed mood, loss of pleasure, or what we call anhedonia, lasts for most of the day, at least for 2 weeks, has at least 4 additional physical and cognitive symptoms, as you can see listed there. Here's the criteria for that. Manic episode, very elevated expansive mood for at least 1 week, very inflated self-esteem, decreased need for sleep, talkativeness, flight of ideas, pressured speech, etc., impaired and normal functioning. There's the criteria for that. Hypomanic episode, a little less severe version of mania, at least 4 days, fewer milder symptoms, less impairment, less problematic in and of itself. There's also the mixed features type of mood disorders, which has a little bit of an element reflecting very balance of mood. We can have some mania with some depression, or we can have some depression with mania. Major depressive disorder overall, clinical features is that it's one or more major depressive episodes that has some periods of remission. Single episodes of major depression, very rare. Reoccurrent episodes, much more common. We used to think that you couldn't be depressed during grief. Now we have a different perspective on that. When we begin to see at least 2 years of depressed symptoms, then we're beginning to look at persistent depressive disorder. So that's a person that for most of the day, more than 50% of their days, they experience some depression. They can have this for over 20 years and can have some severe major depressive symptoms with it. So, what does it look like? Mild depressive symptoms without any major depressive episodes. Could be a pure dysthymia. We might have some mild depressive symptoms with additional major depressive episodes, which may look like double depression. And then we may have major depressive episodes that lasting at least 2 years, which is that, again, persistent major depressive episode. So PDD looks like has 3 different approaches there. Premenstrual dysphoria disorder, again, controversial. Why is that? Because there are some disadvantages, and it pathologizes an experience that's normal. There's some advantages in that it legitimizes the difficulties that women experience with those symptoms. But it is a significant depressive symptoms that occur during menses, during the majority of the cycle, and do lead to distress and impairment. There's the criteria for those. There's also disruptive mood dysregulation disorder. This is severe temper outburst, usually seen in kids 6 to 18. Doesn't meet the criteria for bipolar or hypomanic, and oftentimes historically has been set up to counter so much overdiagnosis of bipolar disorder in youth. There's the criteria for that. Then there's bipolar 1 and 2. Bipolar 1 is essentially full manic episodes and major episodes, depressive episodes. 15 to 18 can be seen in children, tends to be chronic. Suicide oftentimes is a major consequence of that. Bipolar 2, a little different than that. It alternates between major depressive and hypomanic episodes. When you see the stats on that criteria. Then the third is cyclothymia disorder, chronic version of bipolar disorder, alternating periods of mild and depressive and hypomanic symptoms. It doesn't necessarily meet the criteria for full major depression nor full manic episodes, but can persist for a very, very long time at least for 2 years, and 1 year in kids. So it's a little bit more severe than bipolar 1 and 2. All right, I see that the average age of onset is during adolescence, more common in females. And we see that when we look at mood disorders across the world, we know that 16% have major depression, that females are more likely to experience depression, major depression, whereas males and females both have equally bipolar disorder, with women having a tendency to experience more rapid changes with regards to mood, and women being much more in the depressed part of the cycle. Less often in prepubertal kids, seen a rapid increase in adolescents as well as a rapid increase in over 65. We do see that bipolar looks the same in children, adolescents, and adults, and that we know that depression exists across all cultures. 3 months old can show depressions, okay, or mood disorders. Young kids can look a particular way, but not necessarily be manic or bipolar. Not necessarily look directly mania or manic or bipolar. Oftentimes look ADHD, looks oppositional defiant. So we're concerned with kids being diagnosed as bipolar too frequently. Elderly are increasing in their diagnosis of mood disorders as well as anxiety disorders. Cultural differences exist, although Native Americans have 4 times the amount of depression or symptoms and disorders as the general population. We know that there's a high correlation between genetics and the development of bipolar disorder, as well as some other mood disorders. We look at twins. We know that twins have a high prevalency rate, concordance rate between identical twins. So there's very much a very strong heritability and genetics there, especially for females, and some disorders. So twin studies show that there's a high inherited vulnerability for unipolar and bipolar disorder. Neurotransmitters, we got the serotonin, norepinephrine, as well as dopamine that are involved here. So we know that mood disorders are due to low serotonin. And when we have low serotonin, then that allows those other neurotransmitters to really vary widely, and thereby increasing our vulnerability to depression. We also have the hormones, endocrine system that are involved, and what we see there is that we have elevated cortisol levels. We have stress hormones that are really kicking in quite high there. We have sleep disturbances that really become kind of the hallmark of mood disorders. Excuse me. And we know that how people with depression present mood disorders is that they are very rapidly into REM sleep, and that they can improve with regards to time and sleep. Stressful life events. Obviously, stress causes problems with mood disorders. Oftentimes, there's a poor response to treatment whenever the stress is actually precipitating the mood disorder. So context of life becomes incredibly important. Obviously, there's a gene-environment relationship there. And then obviously there's a strong relationship between stress and bipolar disorder, mood disorders. Learned helplessness theory is that whenever we perceive that we have lack of control over our life events, then we begin to develop some hopelessness, helplessness. And Martin Seligman is the first person to ever experiment with that idea. And you remember the dog on the shock pad not being able to escape his environment and thereby gives up completely trying. So what happens as a product of that is a negative cognitive style. When we do look at attributional style, we say that internal, stable, and global attributions all play a significant role with regards to how we think, and thereby causing disturbance of mood and depression. Internal attributions or negative outcomes are my fault, so therefore I have a lot of self-deprecating thoughts. Stable attributions mean that I'm thinking about my future and I'm thinking that negative outcomes are going to be due to me, my fault. Global attribution, I'm going to think about negative events happening throughout the world really disturbing and disrupting life activities. So all three of those things go into play with regards to creating learned hopelessness. Psychologically or cognitively, when we look at the cognitive distortions or cognitive errors, we see that people have a tendency to interpret events in a negative way. They overemphasize negative aspects of a mixed situation. They overgeneralize. in situations, so they begin to think very negatively about themselves, about the world, and about the future. Obviously, marital dissatisfaction plays a very significant role with regards to social and cultural dimensions. And that women obviously experience more mood disorders than men because women seek treatment more. Women have also high comorbidity with anxiety disorders, and women also have a stronger perception of uncontrollability. They're parented to be less independent. They're more sensitive to relationship problems, and then they often ruminate more than males. So whenever we see other cultural dimensions, we know that people that have a lack of social support experience a higher rate of depression. But with substantial social support, you can get better. So we want to look from an integrative perspective and look at the impact of a biological vulnerability combined with psychological and social factors. And we know that when we have a vulnerability that's pre-existing, an overreactive neurobiological response to something like stress, then we know that anytime we encounter something in the environment that biologically we have that vulnerability, and then maybe cognitively we are having those cognitive distortions going on, and so we then begin to have that existing vulnerability of cognitive distortions plus biological vulnerability plus maybe lack of support, marital problems, etc., all coming together in an integrative kind of approach and creating what we call a diathesis stress model, thereby really having a three-prong approach to the development of mood disorders. So treatment, antidepressants through SSRIs, tricyclics, monoamine oxidase inhibitors, mixed reuptake inhibitors. We know that 50% of the patients' medication is beneficial, 25% actually achieve normal functioning. SSRIs block the reuptake of serotonin. Prozac is the most popular, although it has a higher risk for suicide with teenagers. Tricyclics are tofranil and Elavil. We don't really understand how they work. We think that they probably block norepinephrine and other neurotransmitters. Negative side effects is that they cause weight gain and drowsiness, which is pretty common amongst many medications. And what happens whenever people begin to experience negative side effects of medications, they discontinue their medication, and therefore it's hard to determine what will be effective for them. Mixed reuptake inhibitors block norepinephrine as well as serotonin. Effexor is one of those primary examples of a mixed reuptake inhibitor, and it has lower side effects than SSRIs. MOIs really blocks. It blocks MAOs. It breaks down the serotonin and norepinephrine. It's effective. However, it's very dangerous in combination with certain foods and other medications. Lithium, long-standing treatment for especially bipolar disorder. It's a common salt. Stabilizes the mood, both manic and depressive symptoms, and has to be carefully monitored because it can become toxic. It's effective in 50%. But we really don't know how it works. Then you guys have heard of ECT, electric convulsive therapy, another treatment that we don't know how it works, but we have to use it in a case where depression is non-responsive to medication there. So it's kind of the last resort. Does it have negative side effects when it comes to short-term memory? And then this one I'm not familiar with, transcranial magnetic stimulation. There's the use of magnets to generate an electromagnetic pulse in a certain part of your brain that's producing those neurotransmitters, probably of serotonin, norepinephrine, and dopamine. Can be combined with other medications. So I'd say that the vote is still out on that one. Cognitive behavioral treatment, interpersonal therapy, and prevention. That when we think about psychosocial approaches, CBT obviously is one of the most effective approaches to mood disorders as well as a wide range of other disorders. Interpersonal psychotherapy looks at fixing problematic relationships, but the best approach is prevention overall, in that it probably is a better way to approach treatment of mood disorders, since some individuals are non-responsive to medication and or can become non-cooperative with treatment. All right, so for bipolar disorder, lithium is number one, but psychotherapy we know does help in those situations with bipolar disorders. Suicides, 11th leading cause in the USA, although we think it's pretty it's much higher than that. Second leading cause of death in college students, most common amongst whites and Native Americans, most common in females. Females attempt more, whereas males complete more, and that's because of lethality of weapon. Although we see suicide increasing across multiple cultures, Japan, China, etc. Who's vulnerable for and at risk for suicide? Here's the list. Suicide in family, low serotonin, pre-existing psychological disorder, alcohol use and abuse, stressful life event, past suicide attempt, plan and access to lethal weapons. Suicide contagion. We've heard about these happening. The media has a tendency to romanticize and sensationalize suicide, so there's actually ethics when it comes to communication and media as to how much information they should actually show on suicide. Suicide prevention is the best approach to treating people with mood disorders that have a propensity towards suicide. And what would you do? You would have to do a risk assessment. You want to develop a safety plan, maybe even a contract with that person, involve the support systems there, and remove lethal weapons. What do? You want to talk to somebody if you think they're at risk for suicide. So talking to somebody doesn't give them the idea of suicide. Here's the suicide support line, so please make sure you share that with someone in case you need to, or yourself. Okay, we will skip through that summary and go ahead and pause